me share the screen. Boom. All right, so remember, if you have any questions, just go ahead and holler out. And but so this is the last chapter in the unit, and we're looking at the hand. And as you noticed, as we talked about in the last lecture, the last live session, that majority of the muscles of the fingers are actually here in the arm. So you have this delineation between extrinsic muscles and intrinsic muscles. Intrinsic muscles meaning the muscles of the fingers and the hand all originate distal to the wrist, so they're all here. So like you got the interossei and the different brevi muscles. And then you have extrinsic muscles that originate outside or distal, proximal of the wrist. And so they're all here, like either on the common flexor aspect in the medial condyle or the extensor on the lateral condyle. And they shoot their tendon slips down through a lot of all the flexors, almost all the flexors are through the retinaculum there, through the carpal tunnel. And then the extensors are obviously coming through the back. And so what this really, from a hand perspective, where you can get really deep or detailed is in all the different types of hand positions that you go into. And this is really big in the field of occupational therapy, and where you get the misnomer that occupational therapy deals with the hands and physical therapy deals with everything else. And the reason why that originated is that the things that you have to do from an occupational perspective, like tie your shoes, feed yourself, brush your teeth, they require some manipulation of the environment or the object. And so you have to hold things in certain ways, either with like a cylindrical grip or a pincher grip, or however you look at that. And from a physical therapy perspective, we look at, can you grip onto a bar? Can you grip onto something? Can you hold onto a walker or a cane? But for the most part, we're looking at the gross motor function of, can you stand upright while you do that? Do you have the appropriate response in the foot and for balance and stability? And can you coordinate the pelvic girdle and shoulder girdle for functional movement? So this is where the occupational therapy comes from, like, specifically to the hand, to the wrist. And but as I was sharing with you guys last week, that a lot of issues that stem in the hands that would be occupational therapy type aspect, if you're looking very focused at, like, say, the carpal tunnel, a lot of times these things are stemming not because of dysfunction here, but because of instability up the kinetic chain. So now you get into the whole neck, even like your jaw position or lack thereof, and that can create instability in the cervical spine that then creates this whole chain reaction of scapular instability and then down into the wrist. So we do deal with the hand, but more from an indirect perspective. But we'll look through what the chapter has here, and I think they do a good job. It's uncommon to find a hand unit in a functional anatomy textbook. Like when you look at like the Floyd textbook from McGraw-Hill or even the Newman textbook, they don't get into the hand as much, but it's still a fascinating aspect. For the purposes of here, for the exam coming up, the big focuses I would take away from this chapter are more the musculature, like more through the wrist, because you will see as a physical, I mean, just I was at the hospital this past weekend and I had 4 falls that resulted in wrist fractures, and you had all this non-weight bearing because of these fractures. So you'll be dealing with this a lot. But then, so understanding the musculature, like the interosseous membrane between the radius and the ulna, and how that transfers forces, and the radial position depending upon hand position, and then your different types of grip, like how you hang on to things or have to manipulate objects. I think that would be the big focus. So if you knew the extrinsic muscles really well, because those also happen to flex the wrist, and then you got into a little bit of the intrinsics, and then understanding wrist positions, and of course the most common wrist thing, pathology, is carpal tunnel. And so understanding that that's the median nerve going through the carpal tunnel, that space shares a lot of real estate with the flexor tendons and some of the adductor muscles for the thumb, and that mostly none of your extensors, because here's your wrist, you got the carpal tunnel here, your extensors are going to be in the posterior aspect, that you're really not going to have any extensors dealing with that. So here I got the older edition. This is the 5th edition of the textbook because I have a PDF of it. I just find it's easier to navigate than the website. So some of the images are going to be dated, or not dated, but they're not going to be the exact same images. But as I had shared, you have your like just with the wrist, you had your different divisions. You have the same type of divisions out through the hand. You have your distal, proximal, and or, I'm sorry, distal, middle, and proximal phalanges. You have your metacarpals and your carpals. When you look at the available motions here, what we would normally think of like flexion and extension, like we can easily view what flexion of the fingers look like and what extension, because that's consistent with like wrist flexion and then elbow flexion. And so flexion coming forward. When you start looking at the thumb, like what you would think of like thumb, and because it's at a different angle and because we have this opposition, what you would normally think of in terms of flexion and extension, you would probably think like that would be more. So if my fingers come in towards midline, this would be adduction of the fingers and abduction of the fingers. And you would think that the thumb kind of following suit would be the same, that this would be abduction. Well, it's not. This is actually flexion, and this is extension of the thumb. And abduction and adduction would be more what you would think of flexion and extension. So that would be adduction and abduction. So the thumb gets this weird aspect. So just make sure you know that this is flexion and abduction of the fingers, and the thumb kind of following suit. This is actually flexion and extension, and ab and abduction is more of this. So this is flexion, extension. And then you have, when you bring your thumb to your pinky here and coming back out, this is your repositioning, I'm sorry, opposition and reposition, opposition, reposition. So that's where the term opposable thumb comes from, is that we can come across like at a diagonal through midline. We can basically collapse the hand together there. This is opposition, reposition. So now we start getting into the bony landmarks and the ligament structure, and that's really the big thing, is that you have your thenar eminence, which is the thumb, and you have your hypothenar eminence, which is the pinky, the fifth digit, and then you have these the flexor retinaculum, and this is what creates the roof of the carpal tunnel. So you have the transverse carpal ligament and the palmar carpal ligament, and you can see a cross section here. Actually, I like the image better from the let up. So this is it. And so this is the distribution of the median nerve. And so this is the sensory distribution. So thumb, pointer finger, middle finger, and then the half of the ring finger. And you can see the middle, oh, you know what? I can't zoom in, so I don't like that. Oops, too close. Okay, so this area here is the, not what I wanted to do right there. There you go. My thing is not working. Well, my screen markup tool is not working right now, so sorry. Right here is the carpal tunnel, and you can see the slips of the flexor digitorum profundus. You can see the tendinous slips of the flexor digitorum superficialis. So remember, these are these we looked at from last week. Because of their moment arm from the wrist, these are actually some of the most powerful wrist flexors, even though they're not technically wrist flexors like in the name, but they are powerful wrist flexors. But remember, they're sending their tendons all the way down, and they're coming all the way out here. So the profundus is coming to the distal end of the proximal phalange, and the superficialis is coming to the distal end of the distal phalange. And these are your powerful finger flexors. And if you were to like maximally, if you wanted to, let's say you had a rehab exercise that wanted to put you in a maximally shortened position, and you wanted to kind of build up grip strength, you could do that through, if I do this, I'm working the flexor digitorum superficialis and profundus. But if I do wrist flexion first and then do the hand flexion, I'm putting the muscle in an extreme shortened position. And if I had a rehab exercise that wanted to hold that isometrically, that's what I would be doing. You can see that the flexor pollicis longus is in that slip area, and then you can see the median nerve right there. So then if you had irritation because of some kind of tendonitis or inflammation or tendinosis, you would think of it like catching fire. It can start to encroach upon other areas, and not because tendonitis is contagious. What happens with tendonitis is you actually get like swelling. And so what caused this in the first place was irritation, mechanical wear. And getting tendonitis and tendinosis in one of these flexor tendons, it could encroach upon the space and then cause more issue with these. And then what ends up happening is that encroachment starts to put pressure on the median nerve. And the way you want to think about your nerves, particularly in this case, are like tubes, like hoses. And there's a certain amount of information flow. And if that space gets encroached upon and you get a little kink in that, that flow is interrupted and you start to get either motor weakness. And if you don't get motor weakness, and usually it's sensory first, you start to get sensory. So you start to get like either burning sensation or altered sensation or tingling. You just get these weird sensations. And they try to, as we talked about last week, they try to deal with this with anti-inflammatories or change position. It could be because of the way someone's holding a mouse. And, a lot of times it's putting the muscle in a short position, so like wrist flexion, and then doing a lot of grip work that makes the muscle have to work harder, that puts a lot of issue on that tendon. So they might try to change ergonomics or position first, but then worst case scenario, if they come in and they have to cut this, flexor retinaculum to make space for the swelling to allow it to calm down. So that's looking, when you look at the extension mechanism, the extension mechanism is a product of the extensor digitorum, or the extensor digitorum. And it has a similar relationship like the flexor digitorum. It's up here, instead of being on the medial condyle, it's at the lateral condyle, and it comes down the course of the arm. And if you actually just kind of do extension with your fingers, you can feel that contract right here. So that comes all the way up and it goes to the distal end right here, the distal phalange at the proximal component there. And it works in conjunction with the interosseous muscle, so you can do all types of different extension components. I got to be honest with you, I don't think I have any questions on the exam of looking at this mechanism. The mechanism is really cool from it's interesting perspective, but I'll just give you that right now. Don't worry too much about this extensor mechanism. What I would focus on are the arches, the different arches of the hands, the tissues or things that are coming through this canal, and understanding some of the implications of how you would remedy that, what issues are happening, and what kind of symptoms you might get. So then the rest of the is looking at the musculature, and it starts with the extrinsic muscles. And so here's the flexor digitorum superficialis. Again, the bulk of the muscle belly is in the forearm, and you can see that it's shooting its tendinous slips all the way down through the retinaculum, and it's hitting that proximal end of the middle. It should be. Did I say that wrong? Let me see the digitorum longus. Okay. So I mixed them up. I said superficialis actually, but the profundus is the more distal one. But you can see that here's the flexor digitorum superficialis. There's the flexor digitorum profundus. The profundus is the one that's going all the way down and kind of matching the extensor digitorum, and it's hitting the proximal end of the distal phalanx of the phalange. So just make sure I remember that being in some anatomy classes that I've taken, that they obscure some of the words because you're looking for like the proximal end of the distal or the middle of the. So just make sure that you're keeping track that it's the proximal end of the bone, and you're either talking about the middle phalanx of the phalange or the distal phalanx of the phalange. But both muscles have the bulk of their muscle belly extrinsic, and these are the strongest wrist flexors, and they're the strongest finger flexors, and they don't exist within the hand at all. When I visualize these tendons, like if we look up here, hopefully you guys are Star Wars fans, but there's that one scene with Luke and he's kind of checking his hands and you can see the tendons moving up, the mechanical tendons. If you were to open this up, that's what you would see. You would see these tendinous slips of all 4 tendons of the flexor digitorum and the other 4 there. So you see 8 tendons that are going back and forth. If you ever the opportunity to do cadaver dissection, it's cool to kind of, yes, we do these weird things with the specimens. So there's the flexor digitorum profundus, and then there's the flexor pollicis longus. This is another one of the tendons that is going through the. So it's easy to remember all the flexor tendons are going through there. Where you could get a little confusing is that the flexor pollicis longus is the other tendon that's going through that carpal tunnel area. So those two muscles, the flexor digitorum and then the flexor pollicis plus the median nerve, those are all the things in that compartment. How's the adductor? Yeah, flexor pollicis. So like I said, the rest of it's just muscles. This is always a fun thing about the, and looking at anatomy, it's called the Anatomical Snuff Box. And if you, I don't know if you can, you take your thumb and kind of go into adduction and extension, you can kind of make a little divot there where the extensor pollicis and both longus and brevis make a like little area there, like what's called an anatomical snuff box. So that's just a combination of this tendon and these two up here. These kind of merge into the similar aspect, just have different distal attachments. So you can see the adductor pollicis, extensor pollicis, and the longus and brevis, and they make this anatomical snuff box. It's always a fun test question, and I'll be surprised if it's not on the test. I gotta look at the questions again, but I think so. If you just understand that these three muscles are part of the snuff box, you will probably be good with that question. There's no other clinical significance about it whatsoever. It's just so anatomists are kind of dorks. They like to focus on some of these things, and we like to think of ourselves not as dorks because we like to look at from the functional perspective, the application, and they're really outside of just putting like some tobacco or cocaine there, whatever they used to snort, and they would put that there, and that's all that it served was the ability to get high. So I don't know. Maybe they're not dorks after all. So then you start getting into the intrinsics of the hand, and you can see you have the thenar eminence and the hyperthenar eminence. So you got these muscles here that control the fifth digit, and then the muscles over that are going to be bulking up over here that control the first digit, and then you got everything in between. And again, what makes human anatomy unique is this ability to go into opposition and reposition, opposition and reposition. So when you start looking at some of the muscles of bringing the thumb to the pinky and you start looking at that closing in to form those grips, you start to bulk these muscles together. But you have your adductor pollicis brevis, and most of these muscles have originations on the carpal bones. So just kind of knowing that where those are originating from and which bone, I think would be an important aspect of like the adductor pollicis brevis, that it's originating and where it's inserting at, and kind of knowing those components. But I wouldn't mess with like the palmar interossei where you have multiple versions of those, or the dorsal interossei, so much. But like I would definitely kind of know these four here: the flexor pollicis, flexor digitorum, and then these two here, the opponus, and the one figure 12, 23, 13, 24, and 22. Just kind of know those attachments. And again, know them because of the importance of this opposition and reposition. So the ability to make a fist, it's kind of taken for granted, or extension, and that extension mechanism is cool, but where we're going to look at is this opposition reposition, more so from grip, and then more so from a practical aspect of, are you able to appropriately grip a walker or a wheelchair or a assisted device, or hang on to a bar or a broom or whatever your exercise implement's going to be. From a sensory perspective, looking at the median, radial, and ulnar nerve, you're getting innervation down all of it. So you're getting sensory feedback through all three of those. And so kind of knowing your hand distribution, and like we said, with the median nerve, it's going to be the thumb, the pointer finger, the middle finger, and the half of the ring finger. The ulnar nerve is going to take care of the rest of the hand. And then make sure that the difference, you can see that the radial nerve has the bulk of the dorsal surface of the hand, and the median nerve has the bulk of the volar or palmar surface of the hand. And then your Your ulnar nerve is like your karate chop. It's going to be like it's going to be both the dorsal and palmar surfaces down through here, and then it's going to be split between the median and the ulnar nerve. And then the median nerve is the nerve that's affected during carpal tunnel. So this is where you're going to get that on the. So like a good test question, if I was going to write a test question to try to really delineate how you, if you know the anatomy, is if you have altered sensation on the palmar surface of the hand or the volar surface, would that be from the median nerve or not? So you'd focus your studying on, oh, it's the thumb, but where you might have missed is the difference between the palmar or the dorsal and the palmar surface. So just again, knowing the median nerve and the median nerve distribution. Okay, so then this is where we get the different types of grips. And what's interesting, if you were to ask a bunch of people, like when I don't know if I did this in my videos, I can't remember, but if you were to make a fist and put it out in front of you and you were to squeeze as hard as you can, most people think that your grip strength comes from your pointer finger and your thumb, right? And this is where your fine motor skill is. And if you look at some of the musculature, you have dedicated muscles that go to the thumb and the pointer finger. But the bulk of your strength of your grip is actually comes from your third, fourth, and your fourth and fifth really of your finger flexors. And so if you make a fist and you squeeze really hard, you can actually see that this doesn't move so much. But when you increase your force output, the knuckles of the fourth and fifth finger they come down and squeeze down. So that's actually where your grip's at. And if you knew or work with any wrestlers, wrestling, even weightlifters, the thumb is more for control. It's not there for grip. That wrestling grip is actually a thumbless grip. You actually kind of hang on like this, and when you grab the bar, whether the thumb's there or not, is more for control. So your grip strength, the power of your grip, actually comes from the pinky side of the hand, which was you usually think of the pinky as being the weaker finger than the thumb, but your grip doesn't so much matter from here. And again, it comes from the aspect that the thumb is in a different plane than these four fingers, right? If I look at the thumb kind of comes down this way. So if I look at finger flexion, that's there, and thumb flexion is kind of there coming down, right? Which looks like adduction. So this is the thumb's in a different plane, so it doesn't contribute to that gripping strength. So your power or your strength actually comes from your fourth and fifth met. So you have these different types of precision grips. So you have like the fingertips coming together, like the OK sign. You have the overall hand grip. You have the pincher grip. So you have like this grip here, and you have that grip there. So just kind of understanding where you would use each of these grips. So just kind of knowing the precision grip, knowing the actual musculature behind it. I don't think it's important, but knowing that there's different types of grip. So like if you were going to use a walker or a cane, which grip here would be the most important, right? I don't think you're not going to need a death grip on there. So you don't need a power grip. Hopefully, maybe you might be progressing someone to use the walker less. So you might have used like a precision grip, just fingertip. But I think a cylindrical grip is probably going to be your most appropriate grip for using an assisted device. For functional tasks, you're probably not going to do a lot of cylindrical grip. So if you were working with an occupational therapist, the ability to open jars, or more importantly, the ability to hold a knife or a fork to feed yourself. So you're going to get more of these precision or fingertip type grips. So just kind of knowing that these different grips exist, that it's not just, hey, can you grab onto something or not, but understanding that there's different ones and there's different reasons for those or different needs, I think that's important. Now I take a poll, how many people actually hold their pencil like the appropriate way, and then you got some people that hold their pencil like this, and then it ruins your ability to use chopsticks, so you look like an idiot when you're trying to eat. So the pad grip, the lumbrical grip. So yeah, I put it in the study guide and I made it in the announcement, but I think these points to remember here are great. And I think they're in the other textbook, but they're definitely in this edition. They should be there still. But if I was going to do, what I was doing, I was going through making the study guide, and I basically saw these points to remember at the end of the first chapter, and I was like, these are fantastic. This is it covers everything that's probably going to be on the exam or any of the highlights. If it wasn't, I kind of already covered it in this video or in the videos past. And if it clearly wasn't, I added it in addition to the study guide. And then I think these questions are great. They're great. they're great questions because they kind of make you go through the grips a little bit, and particularly like the general anatomy questions and review questions. So what I would do if I was studying for this exam is I would go through and I would read the study guide. I would quickly go to the points to remember, go back to each of those sections in the chapter, use that as kind of like a review guide, and then see how well you do with answering these questions. And if you can answer these questions and you have a pretty good handle of the points to remember, and then in addition to the 4 or 5 extra things that I put on there, and then there'll be some regurgitation from the previous exam. So still understanding the axis of rotation, the plane of motion, which phase is concentric, which phase is eccentric, that's still fair game. That's going to come up on every single exam. There'll always be 1 or 2 questions that are looking at a particular exercise or movement and having you determine which of the phases is eccentric, which is concentric. The only complexing thing now is that you are responsible for some specific muscles. So before we were just looking at, can you name the phase or the groups? Now we're looking at the very specific musculature. Like if you're swinging a hammer, or if you were doing a pull down exercise or like some kind of external rotation post surgery, are you able to identify the eccentric phase, concentric phase, and which plane of motion is that happening in, and which axis of rotation? And I think that's it. Let me switch over to the Newman textbook to see if there's any cool graphics or visuals. So like here, like this is a perfect question. What is the anatomical snuff box? What muscles act as the border? So like if you can answer that question, you will 100% not miss that question on the exam, right? If there was one that pops up. Understanding the thenar versus hypothenar. So thenar is the thumb, hypothenar is the 5th digit. Understanding that that's where the power grip comes from actually the hyperthenar side versus the thenar side. The difference between intrinsic muscle and extrinsic muscles, knowing the common attachment site, those type of things. Oh, now my thing decides to start to work. Okay. So here are the arches. The arch is not so important in the hand because we're non-load bearing. It was really important in the leg. So when we start talking about the foot, we'll spend a lot of time in the arches. I think for the arches, just understanding that there's an arch-like structure within the hand that if you need to, you could put your hand down on the ground and it can support weight. But you have this longitudinal arch that's going from from wrist to finger, and then you have this transverse arch which is going side to side, and then you have a distal and proximal, and you have the exact same architecture in the foot. But it's not as important in the hand because it's non-load bearing. But we will have a longitudinal arch and 2 transverse arches that we'll talk about in great detail, and the whole concept of pronation, supination. But just know that it exists. Question, Susan? No? Okay. Remember, I can't see any chat function because I'm sharing the screen. So if you have a question, you have to ask.
I'm not muted.
What's that?
I'm not muted.
Oh, now you are. Okay. I like this image from Newman because it kind of shows the hinge joint of the 4th and 5th, kind of letting them work as a functional unit. So that's like that grip thing coming in, and you can see that the 2nd and 3rd metacarpal, they're coming in for their strength, and you can see the thumb that has its odd angle coming through. So the thumb is strong, right? But it's not it's not part of really strong grip. But I do like this image; kind of shows the direction of flow with the fingers. Oh, great image. So here it's what I was illustrating here. Here's your 2nd and 3rd knuckle, and then here's 4th and 5th. And you can see that when you squeeze down to kind of hang on to something, the strength is coming from your pinky side, not from your thumb side. Yeah, the thumb too, just kind of making sure that you know that abduction and adduction of the thumb are more similar to flexion and extension of the fingers, and then that abduction and adduction of the fingers are more related to like flexion and extension of the thumb. That's it. I don't know if there's really, I mean, as complex as diverse as what we can do within the hand. There's really not much complexity within the hand itself, mostly because it's non-load bearing. Like the foot is pretty amazing because it has to generate load and do shock absorption, whereas the hand, it gets more into those like the fine, and this is musculature, but it's also like the fine motor control as well. Let's see, put on one more. And you can tell, I mean, you can see that these are the images from the videos that I made. I just like the the artwork. A really good view of the carpal tunnel. So you can see that like you don't see any extensor musculature through here at all. All you see is flexor musculature. You see the median nerve. You see the ulnar nerve is outside of the ligament structure, and you can see that the tendinous slips of the flexor digitorum profundus. You can see the tendinous slips of the flexor digitorum superficialis, and you can see them coming up. Remember, the profundus is profound. It's going all the way to the end, but it's not going to the end. It's going to the proximal end of the, oh, now my pen's working. It's going right there. So it's going to the distal phalanx, but it's going to the proximal end of the distal phalanx. And then the flexor digitorum superficialis is going to the middle phalanx, but it's going to the proximal end of that. You see the median nerve through here, and you can see the flexor pollicis longus. The flexor carpi radialis is kind of showing kind of intertwined here, but it is above that sheath. So you really don't have issue with this muscle as much. It could be involved, but your primary structures are the flexor digitorum muscles, both of those, the flexor pollicis longus, and the median nerve, and that makes up the carpal tunnel right through here. So this is just kind of showing how you can isolate different functions of the finger, and so how the flexor digitorum coming up here, and then your extensor digitorum. But again, I don't think there's any things on there in the test. I think it was last week we talked about tendinosis. We looked at wrist flexion, and this is a review from the first exam, which will make an appearance here. It's this whole aspect of passive and active insufficiency. Understanding that when you're going into wrist extension, you are lengthening the flexor muscles, and so the body's always trying to maintain that little bit of min range, and so it's forcing finger flexion as you go into wrist extension. And when you go into wrist flexion, you are putting length or tension on the wrist extensors, right? As I'm going forward here into wrist flexion, I'm lengthening these guys. So it's putting passive tension, and so it is causing finger extension. So if I go into wrist extension, it causes finger flexion, and if I go into wrist flexion, it causes, and that's just the passive qualities of the extensor digitorum profundus or the flexor digitorum profundus and superficialis. The Newman textbook gets in a little detail how that's used for grip. So if you wanted to, so this is if someone has a little bit of like a nerve impingement or overall like weakness of the hand flexors, you can kind of go into extension to kind of create a grip, right? So if you had trouble hanging on to something, a little bit of weakness, you go into extension to kind of take advantage of some of the passive tension that exists within the muscle. You might have some nerve impairment or damage force production, but you can get passive force production by going into that extension. But let's say you're totally intact, there's no spinal cord damage or injury at all. Your grip, if you look at your hand in neutral and you squeeze as hard as you can, we looked at from this way and we saw that the fourth and fifth knuckles were coming down. But if you look from this aspect, when you go into wrist flexion, or I'm sorry, when you try to maximize finger flexion, you actually go into a little bit of wrist extension. You can see the back of the hand there. What's happening is that you are strongest in mid-range. And remember, from active and passive insufficiency, you're weakest in the shortened position and lengthened position. So your body is always strategizing, trying to keep you in mid-range as much as possible to maximize force output. So if I'm gripping here, If I'm shortening, and we said the most powerful wrist flexors and extensors are also those finger flexors and extensors. So if I'm maximally shortening my muscles here, I'm coming down and I'm gripping. If I'm shortening here to maintain mid-range and maintain force output, I'm actually going to extend or lengthen through the wrist. So when you squeeze as hard as you can, not only your fourth and fifth met coming down, but you're going as you're maximizing finger flexion, you are maximizing. And we either did this last week or I did it in my KIN 230 class. I'm getting them confused now. But if you go into maximal wrist flexion and you try to squeeze as hard as you can, your grip, you're going to have a little sissy grip. You're not going to be able to hang on to anything because you're maximally shortening the muscles at the wrist, and then you're trying to maximally. This is actively insufficient for the supradigitorum or the flexor digitorum muscles. Same thing here. If I go into full wrist extension, I'm going to have a hard time going into maximal finger extension because I've first maximally shortened here. And I'm actively insufficient on the agonist side. At the same time, I may be passively insufficient on the antagonist side. So if I'm here, maybe the reason why I can't squeeze all the way isn't necessarily just because of weakness in the agonist, but also because of passive insufficiency of the antagonist. It's both. You can't have one. You can't tell. And it's always yes both and agonist, antagonist, passive insufficiency, active insufficiency. Just make sure you understand that you're going to have issue gripping here. So if you wanted to maximize grip strength, you would go into extension. And even if you go further into extension, you start to get some issues, but it's just this slight, here's neutral. When you maximize grip strength, you're going a little bit into wrist extension. And I think here, extensor pollicis longus, extensor pollicis brevis, that's the anatomical snuff box, right? Meaningless thing, but just knowing the tendons go there. Maybe it's important to someone, but I don't know. Here's your pinch grip. And here you get that opposition. You get the, the hands coming closer together, the thumb coming towards the pinky. I think that's it. All right. Any questions at all? That was a lot. I think I felt like I did like a huge information. Yeah, so good thing this was recorded. And I think I went kind of fast. So I'm surprised there's no questions. I don't know if I didn't get any reaction. People are tired of popping up in video. Oh, there you are, Eric.
You said in regards to like knowing the certain muscles in the hand, it was a figure 13, 22, 23, and 24.
Yeah, just understanding this aspect, like understanding the opposition. So like flexor pollicis, the adductor pollicis, the let's see if we got them here in this. Or I can switch back over here. Muscles. So definitely muscles. So like the supradigitorum, but like these guys here, flexor pollicis brevis, adductor pollicis brevis, where they originate from, where they attach.
And then nerve innervation too, right?
Yeah, if you look on the blackboard, I stole this from my textbook that I teach in the other class. Let's go. Where is it at? It's under course materials. I should probably start. I just was showing you my screen, and I was not sharing my screen. So I was showing you what I meant to show you was. Am I sharing my screen now?
No.
Okay.
Now you are. Yeah.
Yeah. So yeah, understanding these figures here, 22, 23, 24. So again, more of these guys here coming in and out. And so the other thing I was going to share, because you asked about the innervations. So under the learning modules, under the exam 2, I have these nerve charts here. So I think these are pretty cool. They kind of go through. And I don't think I don't have any questions on the actual nerve root levels, but I do have the nerve. So I think it's too much to kind of memorize all this, but knowing like the radial nerve and who it innervates and the median nerve, yeah.
So are you specifically wanting like a radial nerve being C6, C7?
No, you don't have to worry about
Makes
any of
sense.
these. But like there'll be a question on like if the ulnar nerve, if you had weakness in these two muscles, what nerve is likely the issue, right? So if the question was if you had issues in the flexor pollicis longus and flexor carpi ulnaris, most likely the ulnar nerve or division of the median nerve.
I see. Okay.
Yeah, and that's for all of the, if I go back here, let's go to like the shoulder girdle. Like the pec minor, like if you try to do the nerve roots, it's too much to kind of grasp. So that's why I just kind of did the nerve. But like you have 4 nerves, 1, 2, 3, 4, 5 nerves, and so pec minor, medial pectoral nerve. So if the question was, there might I got to look at it, might be as simple as what nerve innervates the pectoral minor or the serratus anterior. But I think they'll be more clinically oriented where a patient presents with weakness in lifting the arm up over the side, which nerve is most likely impaired, right? So I have this for all the body parts. Let's see, shoulder joints. Yeah. Deltoid, axillary nerve. So I think that's going to be the most difficult thing, is just keeping track of all the muscle origin insertions and the nerve innervation. But you had to do this for anatomy. So now you're doing it again, but you're looking at more from a practical application. Yeah, I think I try to minimize the amount of, there's only so much I can modify in the exams because they're all like because of CAPD and accreditation. But I took some of the bad questions out and made them better and reworded them a little bit just so they're not so confusing. And let me open up the study guide real quick and see if there's anything different on there that I missed. Yeah, so it's not even a whole page, but like I said, this would have been longer, but I think the review questions and the key points at the end of each chapter are sufficient. Yeah, like we talked about the rotator cuff and we looked at the functions beyond just understanding rotation, like understanding that it's compressive into the shoulder capsule, stabilization, that the supraspinatus is the one that initiates abduction. Really understanding the scapulohumeral rhythm. So for every, if your arm's up over your head, at what point does your scapula do upward rotation combined with horizontal or with abduction? What I mean by this with the agonist-antagonist relationship, I've mentioned several times that there's, like when you look at the deltoid, you look at the trapezius, that depending upon the movement that you're looking at, these muscles can be agonist versus antagonist in some aspects. So like if I look at upward rotation, all 3 divisions of the trapezius are working as synergistically to achieve that motion. But if I look at like elevation and depression, now those muscles that were working together are now working as an agonist-antagonist relationship. Same thing with deltoid. If I look at abduction, posterior deltoid, anterior deltoid, middle deltoid are all working as agonists to achieve that task. But if I switch the exercise and movement around, if I'm doing, let's say, internal rotation, that's going to be anterior deltoid as the agonist and posterior deltoid as the antagonist, or shoulder flexion, that's going to be anterior deltoid the entire way, and posterior deltoid is going to be off, right? But if we're looking at, like lateral raise, then that's going to be all 3 heads of the deltoid. And then it gets into that concept of force couples, so muscles that are working together to do that upward rotation, downward rotation. Yeah, the medical conditions. So like the ones we talked about the most were the carpal tunnel and the supraspinatus inflammation and shoulder impingement. But there are quite a bit that are there that I would just kind of be familiar with what those are. You, as a clinician, you need to kind of know that what's going on with these conditions all times, like what tissues are involved, what you can look for, what you're going to see. And then, yeah, I mean, although it's only one page, the study guide's pretty thorough, like in terms of what. And I know you guys are trying to look at to whittle down the information. Unfortunately, it's a lot. I think I whittled it as much for as I possibly can by kind of cutting out some of the hand stuff. But you know, we looked at the elbow. The elbow is pretty straightforward. There's really not much there. It's some muscles and knowing the ligaments, like the medial and the lateral collateral ligaments, like which ligament structures kind of support those. And then the shoulder, it's really like the shoulder and the shoulder girdle mixed together in terms of the combined movements that are there. But if you're pretty comfortable with like the origin insertion and the muscles themselves, and you understand those movements, yeah, that's half the battle right there. Just keep in mind that on this exam, there's 50 questions again. It's 60 minutes, and then lockdown browser, and then I mistakenly, you know, I didn't use the monitor, the Oculus, so you have to use that, so the webcam.
Is there a chance we could have longer time than just 60 minutes?
No, I don't know. Why?
Well, because I don't think 60 minutes is long enough.
Was 60 minutes sufficient last exam?
Well, I think we're covering more detailed information that it might take longer.
But in that argument, see, I always tell everyone that the first exam is usually the hardest exam because there's so many different areas you're pulling from. You're pulling from like nervous system and structural system and biomechanics, and this is all the arm from the shoulder to the fingers, right? So there's a lot of the questions and a lot of the aspects carry over, and majority of the content of the questions, I would say at least half the questions are on previous material in terms of flexion, extension, concentric, eccentric, what plane of motion, and maybe not half, but at least a quarter to a third of those questions. So
I just think if we had a little longer time, we'd be able to think about the question more.
Okay. I'll give you 62 minutes.
Oh, 62. Thank you. Seriously?
Well, I mean, how much time do you think you need? Like, I can give you 3 hours, and then you're going to think about it.
Oh, 3 hours? 70 minutes
like,
then?
Yeah.
70 minutes.
I think most people, the average time to completion of the last exam was like 42 minutes. So people didn't even use the 60 minutes in the last exam. And that's average, right? And that's we'll see. If you know, I don't think I have it where it automatically submits your score, but you do get like, just take your exam, don't worry about it, and see what happens. And then if we see that it's an issue, we can change the time. But
okay.
Focus your energy on understanding what you're doing, not worrying about the limited time. But 60 minutes for 50 questions, that's you got 10 extra minutes built into your thing.
Okay.
I'm going to stop the recorder, but I will definitely entertain questions if, oops. Or kind of go over anything.
Is upward and wait, no, not upward. Elevation and depression the only linear movement of this? Yeah, I feel like is everything else angular?
No, so elevation, depression are linear because there's it's like a direct, and then so is protraction and retraction are linear. The only things that are like pivoting, because the difference between linear and rotational is that you have a distinct endpoint and start point. So with my hand was a scapula, that upward rotation, downward rotation, that's spinning through an axis, whereas protraction and retraction, it's going forward and back, and then elevation and depression. So the only rotation or angular is going to be upward rotation, downward rotation.
Okay.
And that there is a test question on that. So Susan, you just shaved 2 minutes off your test time. So there's your 2 extra minutes. So now you're going to get 64 minutes. Practically.